But last but not least, it's my pleasure to introduce Carly McCoy. She is a licensed clinical psychologist in the NICU and an NICU and infant mental health psychologist over at Denver Health. And she'll be presenting on optimizing family engagement through mental health support in the NICU.
Hi, everyone. Thanks for having me today. Thank you for the introduction. I'm Carly. The only disclosure I would need to make is that my position at Denver Health is currently funded by grant funding from Caring for Denver. And I'll talk a little bit more about that toward the end of my presentation. So I could speak for hours upon hours about this. So I tried to take a really broad bird's eye view to explain to you what it is that we are providing for mental health services in the NICU at Denver Health, as well as how we have implemented this and how the program came to be. Denver Health is a safety net hospital here in Denver. Our population, our patient population is majority Medicaid or uninsured, and that definitely applies to our NICU families. Those babies are majority Medicaid insurance coverage. First, let me tell you what infant mental health means in case you've never heard that terminology. Infant mental health is the growing capacity, the growing brain, the budding behavior, emotions, and relationships of a child. Ages 0 to 5 roughly is how we identify infant mental health. And infants do not exist without their caregivers. So infant mental health also includes perinatal and caregiver mental health relevant to the relationship between the parent and the child. So we're getting into talking about attachment, and a secure attachment with a consistent, warm, nurturing, reliable caregiver is one of the strongest predictors of health outcomes later in life, both physical and mental health. So I practice from a lens of infant mental health. I provide services directly to infants, directly to families in the NICU at Denver Health. So on the left is the NICU in the description of what I'll talk about, the service provided there. I've also been able to provide services in the other units for perinatal, infant mental health, antepartum hospitalizations in these other units on case-by-case basis, but my main service area is the neonatal intensive care unit. I operate, so I'm going to say I because I'm the only provider doing infant mental health services in the NICU right now. If I say we, I'm referring to the NICU team, the interdisciplinary team of wonderful neonatologists, social workers, respiratory therapists, nurse practitioners, physician assistants. We have an amazing interdisciplinary team. So if I say we, that might refer to the NICU as a whole and or my department and myself who have come together to make this program. But in the NICU, I'm practicing from kind of a traditional, it's like a spin on the traditional consultation liaison model. So I provide consultation services. I also liaise between families and medical staff for communication, supportive decision-making, family involvement and engagement. I provide consultation on a proactive basis. So this was approved by the NICU team for myself to go through the census of our NICU patients every day and read about them and their background and identify who would be appropriate for at least one meeting or one session or an assessment with myself as the infant mental health psychologist. So a traditional consultation liaison model has more of a reactive approach where the medical team owning the patient would request that consult. We're doing both here. So proactive and reactive consults. So proactively, I pick up any baby born at 32 weeks or younger, any baby with substance exposure or with parental substance use, any medical complexity outside of prematurity, and that may include syndromic diagnoses, trisomy 21, for example. I also, review parental records, so usually the birthing parent, because parental mental health is infant mental health at that point in time, to look for a history of any postpartum depression, depression in general, history of loss, any other indicators that might, let me know, hey, this family may benefit from at least an introduction and potentially ongoing mental health services here in the NICU. My reactive consults are anybody else who the team requests me to see. So I have a pretty low threshold. I don't often say no to NICU consults because that's my main service area and why I'm there. So if a family says, hey, we had a tough talk about feeding and parents are a little emotional, can you go check in? Absolutely. And so I can go into a lot of detail. I'm going to keep it pretty broad here, but I provide assessment for, coping with the NICU stay. So assessing the family, assessing how the baby and the parent are interacting at any given time, what the baby may be communicating, what the baby's goals are, and helping interpret that to the parents and helping the parents, like we talked about earlier, advocate for their child and join the medical team in the decision-making about what's happening for that baby. I tend to approach things from a cognitive behavioral standpoint, but I also use a lot of other modalities of therapy, just depending on what seems like a good fit for the family. I really try to focus on values-based interventions and motivations. So what's important to the family? What are your goals for your child? Things along those lines. I'm providing an assessment initially, like I said, and then NICU families have access to ongoing therapy as well for as long as they're in the neonatal intensive care unit. In my role in about the last 2 years, I've also had the opportunity to join with other multidisciplinary teams. So OB and midwives outreached me to work together on a response to traumatic birth, so a psychologically traumatic birth. And so I've had the opportunity to work on and implement that workflow, which identifies people who have a risk for maybe, this person dealt with this complication or responded this way emotionally to their birth. They may be experiencing some acute trauma, or they may have been fearing for their life or their baby's life or safety at some point during birth. So we identify them. We offer them a comprehensive psychoeducational packet about what happened and ways to support yourself, resources within the community for mental health support, signs and signals to watch out for if you're concerned about your mental health. And then all of these identified patients also have the ability to have follow-up on an outpatient basis, usually in the baby's clinic. So I'll talk a little bit more about this in a minute. We have a robust team of infant mental health providers across the Denver health system. I'm the representative in the hospital, but our primary care clinics all have infant mental health as well. So families are often getting connected to that infant mental health team at the baby's outpatient clinic when they discharge. And hopefully, I think I missed a graphic. Let's see. Oh, well, I apologize. It didn't work as anticipated, but there was supposed to be an animation that encompassed this whole slide saying anybody, regardless of the unit they're on, has access to the traumatic birth workflow support. So that packet and the follow-up care coordination in baby's clinic, and also general care coordination. So I am providing in-house services as I'm able, and if families need additional services outside of the NICU or ongoing, say, therapy or other mental health type services after they discharge, I'm also coordinating that in the moment in the NICU, either for during the stay or for outpatient. It's nice for us in our system at Denver Health that most of it is internal, so I can provide that connection between hospital and primary care clinic for babies and parents. We also have, short-term therapy available for moms, specifically birthing parents, and I connect families to that type of care as well. There we go. So I mentioned infant mental health programming across Denver Health System. This is the vision and value statement for our infant mental health team. We have a lead psychologist for infant mental health in our ambulatory services, and she and her team came up with this vision, values, mission statement specifically for infant mental health services at Denver Health. It is our goal to strengthen the future of our diverse community by ensuring, and this is my favorite part, every family and every baby is seen, heard, and nurtured across Denver Health and our communities. In the last year, the three of us who represent the different areas of infant mental health, three of us as psychologists, have had the the blessing, the opportunity, the gift to tour some of our C-suite professionals through our areas and talk about the work we're doing, as well as community members interested in hearing about our work. Sorry, wrong computer. Okay, so here's a little bit of the timeline and how this position came to be. The second portion of the timeline is when I came on board. So before I started, our infant mental health lead psychologist did a survey of the system to identify where there were babies and families needing the most support, really. So she kind of looked across the whole system, and the NICU was identified as the highest area of need for infant mental health services. We have a level 3, 25-ish bed NICU at Denver Health. And so she surveyed the system. My department and infant mental health lead wrote a grant, obtained grant funding, and conducted interviews. I was then hired in November of 2021, so it's been nearly 2 years. And I will just say I specifically specialized in infant and early childhood mental health, as well as NICU. In graduate school, I worked with NICU grads and said, I got to get into the NICU. I have to see, that's really who I want to work with and where I want to work. So I also had NICU experience in my postdoc, which made me a pretty strong candidate for this position, I believe. And then I have been building the plane as I've been flying it since then. So actively providing those services as best I can. Some days it looks like triaging the most severe concerns. I see families in person. I will talk to them over the phone. Sometimes we even coordinate video visits if there are big barriers to families being present in the NICU. And then just by being in this role, we've built a little bit of infrastructure. We've strengthened relationships with our medical colleagues, our nursing colleagues, social work colleagues. And I also taught and clinically supervised 2 predoctoral psychology interns last year. In the box that has the X's, it should say January 2022, apologize. So during the year of 2022, I was invited to give some staff education. So I did a nursing continuing education on perinatal mental health and maternal and paternal mental health in general around, the birthing period of life. This is also when we started to work on the traumatic birth workflow. And the only thing we're waiting on really for the traumatic birth workflow is a finalization of making that psychoeducation packet really pretty and on our Denver Health materials and whatnot. And then the goals for September 2023, I made these slides a little while ago. I'm going to edit that to October 2023, just with how things are going so far this month. We'd really like to implement a more concrete screener, or it's a brief assessment of relational interactions between caregivers and infants, and that's called the Welsh Emotional Connection Screen. We also have goals to send out a survey. So we haven't officially surveyed NICU staff yet, and we'd like to get their feedback on the service, on myself as a provider. Is this valuable? Does it support families? Does it support staff? And in the future, we'd love to continue growing this service. We are definitely not meeting every family or every baby's needs, like to a literal degree. I would love to have staff in units other than the NICU to be doing this work and providing this type of support as well, and connections to care. So continuing to build the infrastructure, building the team, resources, if resources are available or when. And we've had some discussions about increasing access to developmental therapies in our NICU. So some babies get some developmental therapy support, but personally, I would love to see that be broader. And we've talked about implementing something like the NIDCAP guidelines or the individualized developmental care plans. And in general, my department has been working on finding a way for this position to be permanent. And so that's kind of where things are at now. And that's my really broad overview. And I would love to take questions. Yeah. Thanks.
Questions? I'll get us started. So you mentioned how there are discussions around sustainability. So what does that look like?
It's a great question. It's a very relevant question. A lot of it has happened on higher leadership levels, I will say. And I think what I'm told is from a resource standpoint, there are funds and there is sustainability from that regard. We're currently having conversations with leadership above the NICU about buy-in and value to continue the service.
I think it reminds me of Heather's talk where it may not perhaps make financial sense, but it's a moral imperative.
Yeah, and I will add the return on investment for infant populations is the highest. So if we invest resources early on and help build healthy families from the beginning, those babies grow into adults who need less from the system.
Other questions?
I wish we could poach you to Children's Hospital. Thank you. That was really great. Is there any focus on trauma-informed care in regards to the nursing staff or the care staff as well? Because that's something that's been really on my mind a lot is, you know, nurses are with those babies probably in the NICU more than any other person in that baby's life. And we know that, you know, 40% of nursing students have an ACEs score of 4 or more. So I'm thinking that a well-rounded approach to infant mental health would also take that into consideration.
Thank you so much for that question. I agree. Well-rounded infant mental health must include trauma-informed care. I would also add that NICU services in general must include trauma-informed care. So I have the luxury that came with my graduate training. I've done a little bit of informal speaking on the matter. I've definitely raised my recommendations to leadership in saying, we've had a lot of conversations about trauma, how we're affected personally, how we may see it play out in you know, nursing relationships or family relationships. It's definitely a popular topic, and implementation of that training does fall to leadership. And I've been invited to speak to our doula team about trauma-informed care specifically. So it takes time for examples of why we may need it and time for that buy-in and that acceptance. Yeah.
It's not actually a question, but if you need help promoting developmental therapy in your unit, I'd be happy to help you.
I wrote down your name, Shannon. Thank you. Thanks, everybody.
Much.